To be so well known. My name's John. I'm a GP from Oldham. Liz, I'll take your Scouse accent and I will raise it with my Belfast accent. And you've all swooned to Patrick and Austin like we always like to do, but if I can get off this stage in 15 minutes and you don't feel vaguely threatened, it'll be a very successful presentation. So, we are emotional practitioners and we talk about love and compassion and empathy, but we also have a good deal of anger. You know, we are not okay with the level of injustice. And so in Manchester, we want to say thank you very much for the inspiration of being here and hearing your stories. We hope that you get inspired by some of the things that we've managed to do. Plainly, you'll work out very quickly who's done all the work and who gets to speak. They are different people, as it always is. And we have taken our love and our anger, we've put tears back on the statistics, and this is our organisation of trying to change things. So this is our non-spirtal deep end flag. We were going to go for the red rose. We thought that would be controversial. So we have the worker bee from Manchester. I'm going to very quickly talk about networks, training, and our practitioner model. And some of you have been taking pictures of slides. You might want to take a picture of this slide. I think this slide should be on everyone's desktop somewhere. The government spent £230 million on this slide that shows that general practice is fundamentally important for health inequalities. Focused secondary prevention and primary care is the fastest way to reduce health inequalities. We've based our entire model on this, and it works. More than that, it's our professional assertion that even though this talks about long-term conditions, we believe that homelessness, worklessness, mental health, it all applies. Secondary prevention in a focused way in general practice is the quickest way to close health inequalities. However, as much as we have the potential to be part of the solution, we're also part of the problem. So, if you don't mind, we like a bit of nitty-gritty, so here's some nitty-gritty for you. In 2016 in Manchester, there were 150,000 people on the Diabetes QoF register. So the whole of Greater Manchester, there was 150,000 people, and all the GPs were achieving high levels and getting high levels of payment from it. But when you do an analysis of just the easiest to attain indicator for diabetes, you discover that actually 18,000 patients don't meet the target, so their blood pressure is raised. 10,000 patients are exceptioned, and actually this is the easiest to achieve target. Where the targets are harder, the exceptioning rises. The record is 32% of patients who have got diabetes being exceptioned in Greater Manchester in one practice, and 23,000 patients in Manchester are undiagnosed who have diabetes, and therefore we end up with a population of 51,000 people in Manchester with diabetes who have no working care plan, and then we wonder why we keep on missing the goal. And so we can sit there and say we're doing really well, and all our screens say green, and our accountants tell us that we've got good income, but 51,000 people. And I stood in a public meeting, a senior public meeting in Manchester, and said, I'm just fucking not okay with that. And some of you in this room are more concerned that I said the word fuck than the fact that there's 51,000 people without a care plan, and we know where they live. We know where they live. So, Glasgow's story started with some academic slippage that Graham very skillfully got onto the shop floor. Our story starts with a plumber who diversified into property management and became the 8th richest man in the Northwest, but never forgot his roots and was passionate about health inequalities. He's called Michael Oglesby, and together with my boss, Laura, they set up a foundation called Shared Health, along the lines of patients having a fair share in their health. And they have given us some headroom in order to give us some funding to do some of the programs I'm going to show you, and give us some space to then start to partner with commissioners and with academics. And so for the last 3 years, we've run Doctors in Deprivation. This is 2016. Graham came and kicked us off. We joined the Deep End movement in 2017. And then last year, 2018, we had our third conference. This is John Rouse, who's the Chief Officer for Devolution. Devolution has been very impactful in our work, and John is a big supporter of the whole Deep End movement. This is my boss, who, even though I'd lived on the estate with my family for 10 years and ran the widest football team you've ever seen, probably the most criminal football team outside the movies, she still had the audacity to wander into my room as a medical student and tell me I was doing everything wrong, and she was probably right. So she set up Shared Health, And we have tried to get our network up and running, and we do study days. We have written to every GP practice who are in the bottom of deprivation in Manchester. 37% of our population are in the bottom fifth of deprivation, and we're slowly building a network through education. However, you don't spend a lot of time in the deep end without starting to worry about workforce and retention. And so we, looking at the evidence base, discovered that our local medical school was the worst at producing GPs, which is a bit of a shame given the need for community medicine in Manchester. And of course, that was compounded by the fact that medical school applications show us that in deprivation you're less likely to apply for medical school. So at the time we thought we were unstoppable, so we organised a meeting. We just hired a room in a posh building. We invited the university, we invited some friends, we invited David. Sorry for getting into this, David. We turned to the university and said, "You're the worst in England, what's that about?" And they turned around to us and said, "We're not the worst, we're the second worst in England." And then proceeded the worst meeting of my entire career, and I still wake up screaming at 2 in the morning about that meeting. And so we retreated back, duly humbled, and through Shared Health we started working on a pipeline, starting in school, with sixth formers, then medical students, then junior doctors and specialty registrars, with the idea that we would attract the brightest and the best. You can't make the NHS the best where it's needed most unless you attract the best to it. And we believe that it's the highest calling in medicine. We enjoy it, you enjoy it, that's why you're here. And we got so far, but then we realised we were going to have to talk to the university again. So we started the charm offensive, we started a evidence-based offensive, and we started a eating humble pie offensive. And we now have got a very productive relationship with the council and with the health authority. The Oglesby Trust are the backers of Shared Health, and we run on top of the normal medical curriculum. We run deprivation modules. So there's 4 weeks at year one where we put them into some really thriving practices with people who enjoy looking after people in deprivation. We have more modules in years 4 and 5, and then we have an amazing module that I have nothing to do with. That for 11 weeks we take some of just the brightest students you've ever met, and they come into not into deprivation general practice, but they spend a day a week in asylum health or with a homeless shelter or doing a bit of politics, and just it's so energizing. And I do believe that we have to absolutely invest in the next generation. So one of our APEP students, who's the 11-week course, asked for some funding and set up a thing called the Health Equity Challenge. And so she gathered together 100 sixth formers and medical students up to 5th year and did a commissioning workshop, all designed by herself, a little bit of help from James, about how do you commission for health inequalities. You know, how exciting is that? 100 young people ready to absolutely take the levers of power and of the money and sort things out for us. So following on for that, we then started to develop our GP training scheme. Any excuse we had to go to Dublin, we seized, and felt very inspired. The college were hugely supportive of this. HEE have funded this. And so on top of the normal Manchester training schemes, we now have a North East Manchester deprivation training scheme that started a week ago. And our first 3 applicants are in the room, and if you could give them a round of applause. And this is Andy, who's the course director, and James, who always has a light bulb on. So that's very exciting. And if you squint, you'll see that every part of so we're doing the normal curriculum, but we also are adding on self-care and the specific skills that we have all learnt in hard-won ways, hard-fought ways in deprivation. So just to finish off with our model, now Deep End have got a model called Link Workers, and when we first started off, we were just overwhelmed with the need. And so focused care is a primary care response to households who are beset by the wicked triad of poverty, complexity, and engagement. We did it because we would have drowned without it. And we just found household after household where we were just not okay with the level of poverty, difficulties they had with engagement, and the complexity that was in their lives. They were not consumers. They were vulnerable households. And we started off in Oldham, which is the most deprived borough of England, but looks beautiful if you get it on the right day. And we started off in a social co-op. So we heard about these terrible APMS practices that Virgin and everybody got. Well, somebody handed one of those contracts, the APMS contract, to a medical student and gave her a prefab hut and no staff and no patients. And I haven't got the time to tell you what's happened in the past 10 years, But now there's 9 practices, there's 31,000 patients, and there's over 100 staff, most taken from their community. And because we came from the community came to us for help, and it overwhelmed us. And so we started a thing called Focused Care, and we based it a lot on the gold standard framework for cancer, but instead of cancer being the enemy, poverty was the enemy. And so this novel worker that we have has all the skill sets and all the additive effects that we get for our cancer treatment, but they work for us and with us and tell us what to do, basically. I've got about 23 bosses, and I love it. So you may have seen the TV program, national TV program a month ago, Deep End, on national television. Yes, great. And so ITV offered to come and have a year with us, and we just didn't want to get distracted or put our patients through that, so we succumbed to half an hour TV program about focused care. We can share it with you if you have a word on the low. It's just general practice done really well. That's what the prefab hut became, which is one of the 9 practices that we have now. This was our very first focused care worker, who is phenomenal and never takes no for an answer. So we started off with her, and then we had another car crash meeting where the commissioners sat us down to tell us off as young enthusiasts and said, I'm not paying you to do gardening groups, I'm not paying you to do a choir, I'm not paying you to have counsellors come and visit patients in their home. And so we then had a weekend of sitting on the floor and going through all the George notes to try and work out where we're making a real difference. We knew it was making a difference because we were experienced practitioners, but we now had to prove it to the commissioners. And this was the very first audit about 7 years ago, which we presented at the college 2013, so it would have been 2012 we did this audit. And the funders just cared that people stopped going to A&E. We really cared about the public health measures that improved in a really hard-to-reach group. But the thing that energised us was that 21 kids got back to school because of primary care interventions, and 22 kids got back to their educational attainment, and that makes you turn up to work the next day. So we got inappropriately confident again and went on the offensive and found some funding for some more focused care workers. And something really interesting happened in our practices at the time. This is our QOF, thank you very much. No exceptioning or very low exceptioning in the areas of deprivation. And we took on some new practices. We put in our models in focused care, and the QOF improved. Suddenly, some of the GPs who had other levers started to listen to what focused care could bring. And then we were very grateful to The Guardian that did an art that is still available. It was the most shared health article of 20, whenever it was, about focused care and how it was different and what it did. And we just try to summarise that focused care is outreach from primary care to go into the health inequality bubble, because that circle of 51,000 people, you get there, the evidence says, if you don't speak English, if you suffer from poverty, if you're a young, angry man, if you've got mental health problems, if you're not a customer. And we use focused care, we use the focused care workers to go into those people and bring them back into amazing universal care that we all do in this room, because general practice is amazing. So, from this article, devolution hit at the same time, and we were challenged to do this at scale across Manchester, and we were offered £2.5 million to do it. Who wants £2.5 million to do a health inequality thing? Thank you. Unfortunately, you have to dance for your supper if you want to have the money. And so we had to not just do the sitting going through our notes, we had to sit down for 6 months with health economists and with managers who didn't really want to give us the money, and we had to grind out the nitty-gritty of why this worked. And the thing that was really interesting, this pie chart shows you that the main beneficiaries of focused care in primary care isn't NHS services. So can GPs have an effect on people's health? Oh no, it's all the social determinants. Actually, GPs have effects on the social determinants of health, because that's what they are, social determinants of health. And so the return of investment, 4.9, please don't ever quote me on that. However, the numbers stacked up, and we were given £2.5 million for a 3-year pilot. And we started off with 1, then 4, and now we are in 50 practices in the most deprived areas of Manchester with 29 workers, which is almost worth an applause, isn't it? Because it's so exciting. Austin and I have a competition going on. I've obviously lost, but thank you. And what's exciting is engaging GPs and seeing them wake up again. The highlight of my working life has been the first day we got our first GPs in, fairly burnt out, lots of have-a-go solo heroes. We got them together in the community, and you know the deep end magic, but we sat them down with our focused care workers and we asked them, who keeps you awake at night? Forget about the risk stratification. You've been a GP for 10,000 hours. Who are you worried about? And they brought out case after case after case. And our focused care workers edit for ate those cases for breakfast. Well, I do this, this, and this. I do this, this, and this. And just to see the most complex cases of these fantastic physicians getting or starting to get solved by these practitioners was just an amazing, and just to see them wake up and get their hope back. So we were double subscribed for Focus Care workers, and the physician feedback is huge. So if you sign up for Focus Care, you get signed up against your will into the Deep End Movement and the GM Education Programme. These are our Focus Care workers who are genuinely amazing and save more lives and do more than I do in my life, and I'm really proud of them. They have a set training course, etc., etc. But of course, because we spent the money, we then had to do some evaluation. So I think I'm just on time if I can just share very quickly the evaluation. So Helen's talked to us about the need for evaluation, and we have a massive devolution evaluation coming. But we were able to get a bit of money to do a proof of concept evaluation with Sheffield, and here's some of the highlights. So we turned the presenting complaints into a word chart. This is scientific, trust me. And as you can see, the presentations of these households are extremely medical in terms of what's going on and how they perceive their problems. But when we look at what our Focus Care workers did to solve their problems, we discovered that there was a whole range of services and tools that they brought to bear. We have discovered this is the old 2013 data, but we've discovered in the proof of concept that we are still seeing a maintenance of these outcomes, but the really exciting thing, which has been amazing, is that for the first time ever, we realized that we were starting to get into employment. So we never touched employment with the first 3 scaling ups, but this time we're up to 2,000 households, and now we've got numbers at scale, so 2,000 households in the first year and a half. 755 individuals in those households stated at the start of the intervention that they were not looking for work. And several months later, 290 of them were either employed or volunteering or actively looking for work. Primary care, change in employment. Embarrassingly, primary care producing employment figures better than dedicated employment schemes, because actually people's health is really important to their work. So we get the idea that work's important to your health, but the other's true. So we were very excited by that. And then we started to understand why people's A&E use evaporated. So that's what happens to a household who've been using A&E as their primary healthcare option. And when they actually start to believe that primary care cares about them and has an access to them, they come back to primary care. So to finish, and I'll say to finish 3 times, Helen, until you work it out. To finish, I can't really show you this, so we might have to bleep this out. But Greater Manchester, we need an exit strategy. So we're almost at the end of our 3-year pilot. We've spent all the money. And so we're going around the localities in Manchester saying, do you still want focused care? So this is from last month. This is a draft of the white paper of public services for the next 5 to 10 years in Manchester. And this is the description of the Manchester model for neighbourhoods. And in there, along with social workers and health visitors, Manchester want to have focused care workers embedded in general practice. So we're really excited by that. Thank you very much. Okay. So I'm going to finish now, and it's with the patient story. We've been a little bit light on patient stories, haven't we? But that's fine. But I was down in London at the college, having a wonderful whatever we were doing, and I got a phone call that convinced me that Focus Care was going to work. And it was from a team who just adopted Focus Care that none of our key staff were working with, and they told me that a patient had come in and cooked them a casserole. And that might not seem that exciting, but this patient had turned up 2 months beforehand in a state at the reception, and instead of booking her an appointment, the team had got her in down the corridor to see the Focus Care worker, and there was a horrendous story of domestic abuse. And if this is painful for you, please do come and talk to someone afterwards. However, this is the life that we lead, and this man had used everything in the kitchen to carry out his attacks. And it wasn't 2 months, actually. It was probably more like 6 to 9 months. But she went through counselling in the practice. The Focus Care worker unpicked the Gordian knot bit by bit by bit, got the right services in. And one day, while I was miles away, this woman brought in a casserole because at last she'd been able to use her oven. And she wanted to cook for her primary care team who'd helped solve her problem. That team turns up to work the next day, don't they? That team has hope. That team gives love. That team wraps up the anger and the love, puts tears back on the statistics, and we just get ourselves organised and we do something about the problems that we face. Thank you very much.